cancer. And how would you think you could begin to get more people into cancer trials? Do you have any ideas on how you might be able to approach those subjects, talk to patients, educate them, anything along those lines? Have you thought about that at all?
Yeah, in fact, talking to a lot of my classmates who are just getting into the medical field, I think a lot of them are they have a very sketchy image of clinical trials. It's like clinical trials, they take a long time. Sometimes we're taught by our professors actually that like there's a lot of bias because industry, they want to have positive results. They want to be able to patent their drugs as early as they can so that they can make more money off of it. And I think just based upon that, like there's some degree of cynicism from students, and I can safely say that it also applies to patients, that like just generally patients tend to be more cynical about it. And I think talking to some people who have had family members who've been in clinical trials, it's just they're afraid that so they're just afraid that the clinical trials, something will go wrong, or there's something that it's like, why should I be part of this clinical trial when there are already 3 or 4 drugs that are more for sure that might work or do. So I think talking to some of my professors, the biggest thing that they said was just for clinical trial researchers and for physicians to be more open, to be more willing to explain the science, to explain just how the new drug works as opposed to the old ones. I think just more openness and more knowledge really gives the patients more power, and therefore they can be more open to.
So you think your faculty members had this bias that you said in the beginning? Your faculty members actually have a bias against studies yourselves? You said there was some bias, or you said that the public felt that bias, that people were trying to get positive results from the trials and not really being open-minded?
Yeah, I think just generally the public, as well as students.
That's true.
I guess my take's a bit different. I mean, that sounds like just an education issue about the value of trials for med schools, one case of view. But for us in Mayo Clinic, I think almost every patient we see ends up on a clinical trial. And so the barrier for us is not the discussion with the patient once we get to see them. And they probably self-selected in fairness because they come because they know we do a lot of studies. So the barrier is access to centres of excellence, I think, where clinical trials are available. There's many patients in Phoenix and elsewhere in the country are treated in community oncology practices by general oncologists. So to me, in myeloma, if the foundation were looking to do something positive, it would be just encouraging through grassroots networking patients to go and see somebody who has expertise and access to clinical trials. I would think would be the most productive way of going about things. Anybody?
We'll move down the line. Oh, so Jesse, yes,
I'm probably a little bit different than everybody at this table. I'm actually a behavioral scientist, even though I'm at the Arizona Cancer Center. So my perspective actually comes from a much broader public health view, and particularly health promotion. I know that this discussion is primarily focused on clinical trials, and not necessarily on myeloma, but enrolling folks pretty much who already have a diagnosis. And I think that as Dr. Kyle alluded to, the issue of getting folks enrolled in clinical trials is rather complex, and it has many different levels. Part of it has to do with the provider. Well, actually, the way I look at it, clinical trials tend to have three legs to them. Well, the primary leg, to a large degree, is the patient or the participant. you have the researcher or the institution who's basically doing the study, and you also have the primary provider who generally is doing the referring to the research institution. Even in Mayo, I would imagine you have community oncologists, as was being mentioned. So, and those three entities have different roles to play in terms of recruiting folks. I can tell you that one of the primary issues from my perspective in terms of clinical trials are what are called inclusion or exclusion criteria. It's not a one-size-fits-all. Studies are looking for very specific kinds of people. And there are a bunch of people who aren't going to be eligible to participate right off the bat. So the question that is going to be addressed drives a lot of that inclusion and exclusion criteria. Obviously, the substance that's being looked at, if it's a therapeutic trial. Keep in mind that there are also prevention trials, which is more of the area that I'm in. But so I think that drives a lot of it. On the patient side, for certain populations, there are huge issues of access to clinical trials. And I'm not just talking about education, just being aware that the trials are there, but really having an opportunity to participate in a trial. And those opportunities are fairly complex. A lot of them have to do with timing, when a trial comes up, and so on. So that's another piece of the complexity. And in terms of the providers, from the research that I've read or have participating on, most providers say that they don't know what's going on. They're not informed as to what trials, or they're not linked with researchers and so on, by and large. And I can tell you that from a provider standpoint, because of limited time and limited resources, the thing that they're looking for is ease. You want me to enroll folks in your trial? What are you going to do to really, the mechanism to facilitate that process? And that's kind of what providers will tell you. And then there are a lot of complexities. If it's a competitive oncologist, is this trial taking business away from me? I mean, those are the more complex issues there. So there are a lot of nuances to it. And I think the second question gets more into underserved populations, so I'll hold my remarks for that part of it.
Well, I tend to agree with some of the things that have been said, but I think it's a layer of barriers that occur, and I think that a good solution, because we can talk about barriers, I don't want to repeat some of the things that we already talked about, but I think a good solution for some of these issues is to develop a sort of a clinical trial navigation system or program that would allow some of these barriers to be addressed. For example, if it's a cultural barrier or a language barrier, well, let's peel that off and make sure that there's a path to the accrual of these clinical trials, or the accrual for a specific trial, whatever the case may be. But simply saying that we can solve an issue with just developing a program, it's also we can't accomplish that goal because it is a complex issue. There is multiple things that happen. There's insurance issue. There's multiple things. There's cost. So those are the things that there's some things we cannot address, but the things that we can and the ones that we should is a combination of education, outreach to the providers, outreach to the PCPs, those very basic things that a lot of organizations are doing, but I don't think that we're coordinating it well enough where you can develop this sort of navigation system for the patient, for the provider, for the PI, so everybody is collaborating on something like this.
So I agree that I think patients are generally very receptive to clinical trials. And I think where the Arizona Myeloma Network can make a difference is really to emphasize for them how important it is. And the analogy that I think is useful is with pediatric leukemia. I think myeloma is in a similar place to that disease maybe 20 years ago, where over a 20-year period with well-designed clinical trials, without any new drugs, they made a dramatic difference in the survival.